record ECG, all that curves, all that, well, deflections. What will be the significance of those?
It's the electrical impulses of the heart work.
Which, well, the feature of cardiac activity. So, if, for instance, the ECG wave will go up, there will be increase of what property of the heart? What will be increased? What will be, well, exaggerated? Any ideas? Yes. This is a dog barking somewhere, so please switch off your microphones, those with the dogs. And again, any ideas, any questions? No, any answers to my question? No.
Professor, hello. Can you repeat
Hello.
the question?
What do we record when we record ECG? Which feature of the cardiac activity will be evaluated?
We'll record the membrane potential.
Membrane potential, no, unfortunately not. That will be quite convenient, but we cannot do that. That's the point, and that will result in some limitations. Yes?
The depolarization of the right and left ventricles of the heart?
Depolarization, yes, but actually indirectly. Okay, let's keep that in mind. So we still don't know what do we assess by the ECG. Again, for those who just well attended the class after I posted the link in the Google class, I'll kindly ask you, well, not to use Google class, well, from the point of view of sources for the link. Try to use a web page that will be a proof of your activity in the class, of your participation, and actually that we have in our classes. Good. For today's topic, we need to. Yes, by the way, that's recommended reading. This is a very nice book that I recommend you to use. ECG from basics to essentials, step by step. Very nice. It was very nice explanations. I think it's one of the ideal books for students. So if you'll be able to find it, please do that. It's very important. It's very nice and easy for understanding. It's quite comprehensive. Okay, so first of all, let's start from the basics of physiology. We have the heart. And you're told in your physiology classes that there are two basic features of the heart. It may be activated, and it may generate impulses by itself. And second is it can conduct impulses. First, there are some specific cells that will be dedicated for development of activation, pacemakers, but from the point of view of activation, actually any cell, not necessarily sinus node or AV node, may generate activation. Any cardiomyocyte may do this. Sorry. Second, from the point of view of conduction, again, we have conduction system. We have his bundle, the branches, Purkinje fibers, but actually any cell, starting from nodal cells up to cardiomyocytes, may conduct impulses. That is important, and that's on one hand will represent actually how can we record ECG. Second, it will be associated to some types of disorders, of issues that may develop in patients' myocardium if there will be disorders of activation or conduction. Good. Again, in your classes in physiology, you're told that we can measure transmembrane potential. There are drawings similar to that with the membrane. that was charged negatively from inside the cytosol, inside the cytoplasm, and positively from the outside, and we can apply it to electrodes. One will be at the surface of the cell, somewhere in the extracellular fluid. Another will be inserted into the cell, typically glass electrode, that will record action potential or other potentials of cardiomyocytes. Good. That's very fine, but point is that that was exclusively in vitro setting. To record scheme like that with action potential, you have to insert electrode inside myocardial cell. Now we cannot do this. We cannot insert electrodes into the cells. Well, our electrodes are not just outside the heart, they are outside of the body. Therefore, first of all, we cannot record directly action potential. Still, we need to know what will happen to cardiomyocytes while they'll be activated. At resting, they'll have negative charge from inside that will turn positive from the outside, and then it will be restituted when activation will disappear. But if our electrode will be from outside the cell, it means that relative charge of the cell in resting state will be positive in relation to the inside of the cell, in relation to the cytosol, and while cell will be activated, positive from inside will mean will be negative from outside. What will happen? First of all, when some pacemaker of the heart, like sinus node, will generate impulse and will activate itself, and then there's some adjacent cells, their charge will turn from positive to negative, again, talking about outside. And while the other cells will not be yet activated, and that will create potential difference in between adjacent cells. So part of myocardium will be activated and therefore charged negatively from outside. Part will still be in rested state and charged positively from outside. So we'll get potential difference that may be measured. But one small, tiny little thing that, again, for that, we need to apply our electrodes on the surface of the heart. So to record that potential difference from location to location, we need to apply some certain electrodes on the surface. Again, we cannot do this. At least when we talk about ECG itself, we can do this during surgery, and sometimes it's done. It can be done while, for instance, stimulation, when we apply electrical pacemakers that will be sensitive for charge of the heart. But that will not be ECG. So again, what actually we are measuring during the ECG? In the ECG, we have some active electrode, or it will be called exploring electrode, electrode E, and electrode I that will be indefinite electrode that will represent the total charge. For instance, in that setting, when the heart will be represented by the piece of the muscle in the tank with electrolyte, it will represent the total charge of the electrolyte. What will measure the exploring electrode? It will measure the change in potential difference in time. It will change the current. It will change the electric and magnetic fields that will be generated, not while there will be a potential difference between the active, that is negative, and positive, that is, well, activated portions of the cardiac muscle. Not that. It will record the change in potential difference. It will record the current. If there will be just potential difference, for instance, one portion of the muscle will be isolated from another. There will be potential difference, but there will be no current. There will be no deflection at the ECG. There will be a straight line here. There will be deflection of the hand of the galvanometer only in the case when there will be, well, change in time, when there will be current, when there will be spread. And that's why the feature of the cardiac muscle, that is, well, conduction, conductibility of activation, is extremely important. we will reflect, we record the conduction of potential difference, change in potential difference. We're recording the currents. Good. So once again, actually, what do we do to our patient will be nicely presented by the scheme. So we have the portion of the muscle that may be activated. That is the activation that may be electrical, mechanical, chemical, any, or maybe inner if there will be some kind of pacemaker inside. And once it will be activated, the activation will spread from that origin to all other portions of myocardium everywhere until everything will be activated. The spread, the wave of activation will not stop. And that will be recorded by our exploring electrode and will be represented by deflection of the hand of the galvanometer. Good. Nice. Once again, we have same piece of muscle, same piece of myocardium. And we have, again, our exploring electrode here. What will change if we will just replace our piece of muscle by another, by a bigger one? We had in our initial setting, some kind of activation and spread of activation from its origin, to the opposite location where we positioned our exploring electrode. What will happen if we will just use the thicker piece of muscle? During the same moment of time, there will be activation of more cardiomyocytes. There will be a more intensive current that will be generated by using the thicker muscle. So if there will be larger muscle, there will be more intensive current that will be generated. And therefore, instead of small deflection, we'll get larger deflection. Wonderful. Even thicker muscle, even larger deflection. So what amplitude will represent will be the strength of electrical driving force, strength, the potency of the current. Good. Another point. What will happen if, again, we'll use same 3 types of the muscle, but we'll reposition our exploring electrode, or will change the origin of activation. And activation will be not going towards the electrode, but will go away from exploring electrode. Again, same piece of muscle, same thickness, same duration. The only difference is the location of exploring electrode. What means same piece of muscle? It means that there will be same amplitude, and by the way, same width of activation. Width will depend upon the time upon which the activation will spread from the origin until the end, until the last pericardiomoyocyte that is not yet activated. So electrical driving force cannot be different. It should be same. It cannot be hidden. It cannot be lost somewhere. But what will change will be the amplitude, the direction of deflection. Instead of going up, it will go down. Same will happen in all other settings. We'll have same amplitude. The measurements will be absolutely similar to that in a different direction. What will change will be the sign of deflection. For instance, instead of the direction rightward, it will go leftward. Or instead of up, it will go down. So therefore, we have 3 basic components that we need to take into account. First is the amplitude of deflection, the degree of deflection. Second is the width of deflection, time. And third is direction of deflection, whether it will go to one side or to another side. If everything is clear up to now, let's go further. Not much further, but again, we have the same piece of muscle, same origin of activation. Again, one single exploring electrode and one indifferent electrode somewhere in our electrolyte solution. We'll change the position of our exploring electrode. If it will be in location from which activation will go away, there will be deflection of one amplitude down. If it will be the location towards which activation will go, it will go up. If it will be in the middle, what does it mean? It means that, the halfway activation will go towards our exploring electrode in third location. So due to that, activation will go up. Then activation will go away, and therefore it means that the deflection will go down. If we'll manage to position electrode precisely in between the origin and the termination of electrode, in that case, there will be absolutely equal positive and negative phases of deflection. So positive will be same as negative, and that will be called equiphasic. Phasic type of the complex, when a positive part will be same as negative part, equal phases. Then, if you move our electrode somewhat well closer to the origin, there will be smaller positive part, while deeper negative part, and vice versa, well closer to the termination, to the opposite end, higher positive, smaller negative. Again, from the point of view of amplitudes, all that patterns will be absolutely same. If we'll summate amplitude of this complex, of that deflection, of that set of waves, and all others, the sum of amplitudes will always be same. Second, width of the complexes will be always same. It's same process, just different location of exploring electrode. Sum of amplitudes, duration cannot be different. It's same very process. What will change is the shape of the complex, is the direction of deflection. And that's interesting, because actually in practice we have no idea where from and where to activation will go. We don't know whether our patient is having normal or abnormal myocardium. We don't know whether activation will go from the normal origin or from, just a second, there are a lot of messages in the chat. I need to find out what's happening there. Good, you are writing your names and group numbers is good, but please try to use the Google form. Hope it's working. Okay, sorry. What will change is the approach from the point of view of geometrics. If we'll pay attention to the sign of deflection, in that case, we'll have maximal negative deflection. In this case, if we will position electrode absolutely precisely opposite, maximal positive deflection. In this lead, there will be zero deflection. In that, negative but not maximal. In this, positive but not maximal. Therefore, according to different location of electrodes, we can predict where from. In that case, we'll get maximal minus, maximal negative. Where to, in this lead, we'll get maximal positive deflection. And perpendicular to which location or lead our activation is going. That is important, and that will be very helpful in prediction of the pattern of activation of myocardium. Well, I hope that you're all acquainted with ECG itself. It's recorded in special paper with small and large squares. That is the direction of paper movement. Therefore, that is the horizontal is the timeline, the vertical is the voltage line, and there should be some certain calibration of the impulses by which we can record deflections. We'll talk about that when we'll talk about the heart rate assessment in more details. Good. Now let's talk about myocardium itself. What we discuss is not just the heart muscle. It's not just well, the piece of myocardium. It's certain quite complicated and heterogeneous organ. And therefore, there'll be certain stages in activation of myocardium, certain phases. First will be the generation of the impulse, if that's normal heart. That will be in the sinus node. Good. The question to all of you will be, what will be the representation of the sinus node activation in the ECG? Well, Gabriel, do you have an idea why there will be no deflection? Ahmad, Siabra. Well, can anybody hear me? Also, why there will be no deflection? There will be activation of some group of cells. These cells will be, well, definitely there will be they'll create potential difference. So let me use another color on the heart. So these cells are activated, and there will be a potential difference between these cells and well other cells. Why there will be no deflection in that case?
Probably because we are at the position of the electrode integration.
Yes, and you think because the spread of conduction will be perpendicular? No, not quite.
No.
It might have a positive deflection and a negative deflection, so it will be.
But there will be no deflection. Neither positive nor negative. Why that? Chabel? Any ideas? Chabel, if you would have an electrode placed on the surface of the heart, if, well, it will be open surgery. In that case, we'll be able to record potential difference. There will be deflection between sinus node and neighboring myocardium, but it's not open surgery. Our electrodes are not recording potential difference. It's not. It's only the currents that will be induced by the spread. And in that case, when activation is locked inside the sinus node, in that case, there will be a no current. And that's why there will be no deflection. These cells, activated cells, will be isolated for some time inside sinus node. And only late activation will be released from sinus node. It will be spread through atria. And in that case, our electrode that I think will position somewhere in the location of the apex. By the way, that will be same as standard second standard lead position. Our electrode will record positive P wave because most activation will be directed towards the apex of the heart, towards our exploring electrode. But then activation is spreading across atria. It's going down. And then it will reach sinus node. It will be activated by the wave from sinus node. And voila, we have another stage in the ECG. That is activation of the AV node and beginning of the his bundle. But now let's talk about AV node itself. Again, why there will be no deflection? Because again, activation will stuck inside of the AV node, stuck for some certain time, and there will be no spread, no conduction yet to ventricles. And until there will be conduction to ventricles, there will be no deflection. It's only, well, conduction that will be represented by the ECG, nothing else.
Professor, do you mean the delay time due to the gap junctions?
Yes. The ECG, it will look like some kind of delay. But for now, we need to understand just actually what we can obtain from that process. So when we talk about those certain cells that will stay, that will inhabit AV node, the activation will have no manifestation in the ECG at all. And now, yes, it was a good question, by the way, concerning delay. Delay means that there will be delay after the termination of P wave and beginning of ventricular complex. Well, that is the delay. And typically, we say that delay is due to activation of AV node. Well, it's more or less true, because yes, there will be delay. And there will be some certain period of physiological line before ventricular activation. But let's forget for some time about ventricles. Ventricles, from the point of view of the state of cells in the AV node, will be important only as a marker that AV node released activation further, well, downwards to the ventricles. So activation of ventricles on set of ventricular complex for us will be important indication that activation is already released further. But there is, again, a very important question. What about the beginning of that process? When it will start? Any ideas? Ahmad Sharifi? Gabriel? Well, nice silence, Ahmad. It's well, you're absolutely correct. We have no idea about the onset of AV node activation. We don't know. Why? Again, because activation of the AV node will result in no deflection. And whether it will start just well after P wave, or there will be overlay of activation to significant portion of P wave, we'll have no idea ever. We can only guess. And that will be extremely important because, well, in our next class, that will be on Saturday, we'll talk about blocks. We'll talk about, well, AV nodal block. And there will be some strange things that I'll tell you about the definition of AV blocks. Those strange things will be related to inability of ECG to reflect direct activation of the AV node. That's important. Good.
But Professor, there's
Yes?
something that I don't understand. How
Good, yes.
do we say there is activation and there is no deflection? How?
Mm,
Are the nodes cells and they have
well,
extensions, like plasmic extensions, or what?
because those cells are well isolated. They live somewhere, like in the keep, somewhere in a locked location, and they'll not release activation for a significant portion of time. So that's from the point of view of histology. From the point of ECG, well, according to the delay, that will pause, that interval after P and before ventricular complex is due to activation of AV node. But the point is that not only that time, maybe some kind of extra time that will maybe overlapped on some deflections, and that overlapped portion cannot be recognized in the ECG directly. That's the point. So we can only see the portion of AV nodal activation after activation of atria will be over and before activation of ventricles will start. Only that portion is visible by the physiological line. There are possible overlay to atrial activation isn't visible. Good. So activation sooner or later will be released to ventricles, and ventricles will be activated in certain phases. First phase is activation of septum that typically will start from the left and somewhat rightwards and upwards. From left portion, so from his bundle to the right and somewhat away from the apex of the heart, and therefore our electrode located at the apex will record negative deflection that will be the septal activation. Then activation will be of the free wall of ventricular complex. It will go to the apex to our exploring electrode, and therefore we'll get positive deflection. Then there will be activation of outlets of the ventricles. It will be again towards pulmonary artery, towards aorta, and away from our exploring electrode, therefore, so we'll get negative deflection. So we'll get up to now 3 phases of ventricular complex, but it's not all. There will be situation when there will be total activation of the whole ventricular wall. Everything, all of myocardium of the ventricles will be active. And again, in that case, there will be no deflection, because there will be a potential difference between ventricles that's activated and atria that's already not, but there will be no current, no conduction. And therefore, fourth phase of ventricular activation, full activation of ventricles, no deflection. Well, repolarization of ventricles is quite a complicated process. Not sure that we have enough time for discussion of that now. For those who are interested in that, again, I can just refer to the book that I already cited. That process, first of all, is quite passive and therefore slow. It's more or less chaotic. If activation is conducted through the conduction system, it's sorry, I need to open the door. There'll be a pause for some time. Sorry. Okay, I'm sorry. I'm sorry, we have to buy antibiotics for our clinic, to give our patients. So, there was a messenger with another set of azithromycin that we use for our patients with COVID infection. Good. So, sorry again. Repolarization of ventricles is first of all will go in opposite direction. So if activation will start from endocardium and the less activated layer in myocardium will be epicardium. The less activated layer, subepicardial, will be repolarized first. So repolarization will go in the opposite direction, though dipoles will be oriented in the same way. Therefore, no matter that it's repolarization, it will still be positive as, for instance, R wave in most of the leads. And U wave is a late ventricular activation that typically is absent. So actually, we consider U wave is abnormal wave that may be in some electrolytic disorders, in well, hyperkalemia and toxicity of some medications. Some terms that we need to apply for the ECG. First is well, always it's P wave. That will be its width. It should be normally within 12 milliseconds. 0.12, yes. Then we have a segment, PQ or PR segment. And that will be the PQ or PR interval. So segment is after termination of P before onset of ventricular complex. Interval is the portion of the ECG including P wave. So that's so-called supraventricular activation that will encompass activation of atria and activation of the AV node. Again, that will be important when we talk about AV blocks. Then ventricular complex, it's not always QRS, we'll talk about that a little bit later. Then will be the fourth stage of ventricular activation, full repolarization of ventricles, normally isoelectrical ST segment, and T wave that will represent a repolarization, and both ST and T are very sensitive for ischemic change, and we'll talk about them I think when we'll discuss ischemic heart disease, well, somewhat later at the semester. Good. Is it clear up to now? I'm afraid that if it was clear, then, well, now it will not be as clear because we need to discuss some terminology from the point of view of deflection or deflections of the QRS complex. Well, first, Q wave is not always the first wave in the ventricular complex. It's just initial downward deflection followed by positive, followed by R wave. R wave will be the name that will be used for all positive deflections, no matter whether it's preceded by Q wave or whether the patient will have no Q wave. All positive waves will be called R. For instance, second positive will be called R with apostrophe. S wave, that term will be used for downward deflection after positive, after R wave. If there will be no R wave at all, in that case, you'll say that your patient is having just QS complex. Capital letters will be used for waves over 5 millimeters. Small letters will be used for waves under 5 millimeters. By that, I think again, I have to refer you for our ischemic heart disease class because it may be confusing for the first. But when I talk about ischemic changes, when I talk about, well, transmural function, you'll find out that it's quite easy, quite reliable, and it's much more logical from the point of view of description of what happens inside the myocardium. Well, I think we already discussed the intervals. Please don't forget that we record on the special paper our ECG, and in the case of standard velocity of recording, standard velocity is 25 millimeters per second. Let me change it to red color. In that case, therefore, if there are per second 25 millimeters, 1 millimeter will be 1/25th of the second. In other words, 0.04 second. That will be the value of 1 small square, 1 millimeter. This paper will have larger readings, larger mesh. That will be 5 millimeters. And those 5 millimeters obviously will be equal to 0.2 seconds. Again, that will be important to remember when we'll assess the heart rate. For the amplitude of the recording, we use standard standard calibration signal. That will signal of 1 millivolt, and 1 millivolt should be equal to 10 millimeters, or 0.5 millivolt should be equal to 5 millimeters. Please always check the calibration. So every recording should be started from square signals, signal indicating the strength of a signal. Typically, for instance, in Russia and in most of the countries, the classical signal, calibration signal, is 1 millivolt. That should be equal to 10 millimeters. Good. Let me erase that. Okay. Well, first of all, please remember that we have some fixed heart rate, the normal heart rate that will be associated to normal duration of QT interval, the width of activation of the ventricles, ST intervals, and if the heart rate will change, even in absolutely healthy patient, even in patient with physiological tachycardia, those intervals representing the activation time of the ventricles, or well, repolarization time of the ventricles will also change. So if we talk about a patient with normal heart rate, let's say, well, 60 or 70, it will be like that. It will be, well, 330, 430 meters per second. If the heart rate will increase, there will be shortening of the QT interval, and there will be shortening of the ST segment. Then PR interval also may change, but it's more or less stable. In adults, PR interval should be up to 200 milliseconds. It should be within 0.2. In children, it may be somewhat shorter. The normal value is up to 0.18. And it's important, that will be used for assessment of the conduction block. Good. How can we assess how can we calculate the heart rate? From the point of view of mathematics, the easiest way will be to measure the duration of the one cardiac cycle. There, for instance, RR interval, if there is diminution of R waves in the ECG, and divide 60 seconds that are in the minute to the duration of that interval, definitely in seconds. Interval, that will be not in millimeters but in second, and 1 millimeter, as we decided, is equal to 0.4 seconds. That is 1 millimeter. Anyhow, it's not quite practical, and there may be some other more simplified approaches. For instance, you may count the number of cardiac cycles or intervals for 3 seconds. In that case, what is measured is 3.5 complexes of the ECG within 3 seconds. And therefore, there will be, within the minute, there will be 15 time spaces of 0.1 second each. And you can multiply 3.5 by 20. So there are about 20 times per 3 seconds in a minute. Therefore, we can multiply 3.5 by 20, and we'll get 60 heartbeats per minute in that case. Quite simple, quite convenient from the point of view of analysis of the significant bulk of the ECGs. Well, that is well another approach. What I told you about in that case, what is used is milliseconds. So 60,000 of milliseconds per minute, and it's divided to interval that is in milliseconds. Actually, same but not seconds, but milliseconds are used. Well, another approach, again, it may look like complicated for a student, but it may be quite easy for a doctor, practical doctor who look through a lot of ECGs during the day. We can pay attention to some certain episodes in recording and measure the distance between complexes in the ECG. So, for instance, if the distance between the complexes will be 200 milliseconds. So the complexes will be very close one to another. In that case, means that patients having tachycardia, and that will be equal to 300 beats per minute. So RR interval 200 milliseconds. 200 milliseconds is one large square, and it corresponds to 200 beats per minute in a patient. Again, well, another set, another large square, another, well, 5 millimeters in the recording. And if that will be the difference in between the neighboring complexes, it means that heart rate, 40 milliseconds, 2 large squares, heart rate is twice less, it's 115. Both may be seen in attacks of ventricular tachycardia. Then again, adding another large square, the distance between neighboring complexes will be 600 milliseconds. In that case, in the case of R interval 6 milliseconds, 3 large squares, heart rate is 100 beats per minute, and so on. So 800 milliseconds, 75, 1060, 1200, 50 beats per minute. So it may be also convenient in assessment of, well, significant load of recordings. Now we need to discuss, well, how everything will look like in the clinical setting. Again, if you have not, well, the portion of cardiac muscle, not, well, the isolated heart, but heart is inside a patient. We cannot, well, get close to the heart. We can use some distant locations for placing of the electrodes, either on the chest or on patient's extremities. So we need to apply some certain leads on the distance from the heart, going, well, closer or more distant. They should be always amplifier, and then no matter which leads we're recording, whether it's classical leads, augmented leads, chest leads, and there will be the recorder with, again, with the paper with certain fixed velocity of, well, typically 25 millimeters per second, very, very rarely. It may be twice, well, higher speed. And if it's difficult to analyze ECG, you may ask your nurse to record ECG or record yourself, and the twice higher speed. So everything will be twice wider. Speed will be 50 millimeters per second, but that is, happens only in exclusive cases. Standard is 25 millimeters per second. Well, what all our leads are for, it's like taking the photographs, receiving projection of some certain, well, three-dimensional event to some certain points or, well, planes. We have 6 leads, 3 classical, 3 augmented leads in the front plane. And that will be like, well, taking a picture of some kind of three-dimensional object from 6 points of view. Again, we don't know what is the shape of that three-dimensional object. We don't know in which direction atria activated and how ventricles are activated. But receiving 6 projections, we can remodel that at least in one frontal plane. And similar approach can be done in the case of using the chest leads in horizontal plane. How it can be done practically? We can apply electrodes on a patient's wrists, ankles. Actually, that is just, well, a technical location because it's more convenient to place well, the steel stuff on the wrists and ankles. But from the point of view of the physics of the body, the actual location of the electrodes will be where extremities are attached to the trunk. So if the steel plate will be in patient's wrist, from the point of view of physics, it will be where arm is attached to the body. Same is for the leg. So from that point of view, we have more or less equal in covent triangle. And in the case of equal angles, all angles will be more or less like which amount? Jabal, Otman Hamid, yes,
60.
60, yes. All angles should be approximately 60 degrees. Good. Wonderful. What we can do? We can reposition those axes, just shift them to one certain point so that they'll all cross that point. And therefore, we'll get, while passing through that central point in the body, one horizontal line. That will be the axis of the first standard lead with positive electrode on the left hand. We'll have a second standard lead. The exploring active electrode will be on the leg, from the right hand to the leg. That will be again at the angle of 60 degrees. We'll go second standard lead, and then again plus more 60, and therefore from the positive portion of the first standard lead, it will be 120. We'll go third standard lead. That lead will go from the left hand to the leg. The positive part of the first standard lead will be taken as a zero angle. So all measurements will be done from that portion, from the positive portion of the first standard lead. If they'll go clockwise, there'll be a positive. For instance, second standard lead will be plus 60, third plus 120. If they'll go in opposite direction, in counterclockwise, they will be negative. Good. Sorry. What about so-called augmented leads? What is augmented in those leads? Why they are called augmented voltage? Don't ask me, I don't know. Nothing is augmented. There will be same amplifier that will be used for those leads as for classical leads. The only difference is that we'll merge the potential, the signal from other, left free leads of the standard leads. So if the active lead will be, for instance, at the right arm, right hand, we can merge potential of the left hand to the foot, and we may compare electrical driving force, the change in potential difference, the current, from in between this certain active electrode and merged reference electrode. And that will give us another direction of the axis of the lead. It will go from in between left hand and the foot towards right hand. It will be. Another location on the left hand, in between right hand and the foot, the lead will go to the left hand. In between hands towards the foot, there will be AVF lead. Again, we have 3 quite regular axes, and definitely the angles in between all of them will be same. Therefore, it will be 60 degrees. What is changed? just their relative position. Therefore, instead of classical 3 leads, that is horizontal under the angle of 60, 120, we'll get 3 extra that will work like a bisector. So, for instance, AVF will go just in between the angle between the second and third leads. This angle will be divided by AVL lead, this by AVR lead. So therefore, the relative step between the set of classical and augmented leads will be 30 degrees. That is for front plane. Besides that, we have also horizontal plane. When electrodes will be located on the surface of the chest, the reference electrode will be represented by 3 electrodes located at the patient's hands and foot. So there will be triple reference electrode for those leads. Electrode will be located in the surface of the chest, in the fourth interspace for first and second chest lead, for fourth, fifth, and sixth, and the fifth interspace, and in between fourth and the fifth on the fifth rib, there will be the placement of the third thoracic, third chest electrode. This how it will go. Location of the chest electrodes. Here they are. First 2, fourth interspace, fifth interspace, fourth by the midclavicular line, fifth by anterior axillary line, and mid-axillary line will be the sixth one. Fifth rib will be for the third chest lead. So more or less that will represent the horizontal plane, just another view for the events in a patient's cardiac muscle. Don't forget that you need to pay attention to the correct positioning of the precordial leads. That may be especially important for women with large breast glands, because typically the electrodes will be for instance, fourth chest lead, third chest lead will be located under the breast gland, and sometimes they may be displaced significantly lower. Or if you'll apply them over, they may be displaced higher than they should be. So in the case of correct positioning of the precordial leads in healthy patient, there should be equiphasic P wave in first chest lead. Equiphasic means with positive and negative phases. And the complex in second chest lead should look like that, should be looking like QS without significant R wave. If your patient will have absolutely normal ECG in standard and augmented leads, and ECG in chest leads will give presentation like that: monophasic positive P in B1, small r will be in second chest lead. It may be that electrodes are placed lower than they should be placed normally, or higher placement may be suspected. Again, if you have normal front plane, but in first chest lead, you'll get negative P. So please pay attention to that. And before starting diagnosing hypertrophies of atria, or some ventricular issues, please recheck what's happening in another plane, in other leads, and maybe just to have to ask the nurse to retake, re-record the ECG in your patient. Good. For the ECG, what do we need to assess will be some kind of summation of the vectors. All of them, unfortunately for us, are three-dimensional vectors. They're not plane, and then the heart is a three-dimensional object. And unfortunately, there'll be some kind of a circle that will be formed by those vectors. A vector of activation of septum, that is initial vector of ventricular complex, will go somewhere from the left to the right and upwards, like that, or like shown here. away from the apex and somewhat rightwards. Then activation will decrease, and the main vector, the vector of the free wall, will be directed to the apex, more or less coinciding to the anatomical apex of the heart. That may give the highest R wave in forced chest lead. And then activation will go up, and will be directed again away from the apex, somewhere to the outlets or the ventricles. So that will do what we need to assess by our standard, augmented, and chest leads. So that will be the projection of the vectors momentarily, or summation vector of the ventricles to the axis of the heart. Well, so what we'll record will be some kind of the task that you may possibly have in your secondary school when you study geometrics. So it may be the projections of the unknown vector to the axis x, y. So that will be given to you. And what we'll have to reconstruct will be the location of the vector. So if you get projections like that, we presume that the vector will be in upper right quadrant, and that may be the vector that you search for. If you'll get positive projection over the x line and negative over the y line axis, that may be the position of the vector you're looking for. Well, however, there may be different situation. You may have quite a significant projection over the 1x, let's say this one, and zero projection over another axis. What does it mean? It means that the vector is exactly coinciding to one of the axes, and therefore its projection on the perpendicular axis will give you 0. So that's also very important and may be well utilized for our purposes. Good. So what we have is the intersection of the set of 6 leads in the front plane and 6 leads in horizontal plane. And each may be used for assessment of rotation of the vector. How that may be done? Like that. If you have highest positive deflection, let's say in first standard lead, that is the first standard lead. What does it mean? It means that our vector will coincide to that axis. And in that case, in perpendicular axis, that is the AVF, you'll get 0 projection. So the straight line that's represented here means that your patient will have equiphasic complex in AVF. If you'll get presentation like that, that will be the angle alpha equal to 0. So mean vector will coincide to the positive portion of first standard lead. Another situation. Let's say you see in AVF highest positive deflection. The tallest R wave of all will be in AVF. Equiphasic, like this, will be in first. What does it mean? It means that the vector is coinciding to the positive portion of AVF and is perpendicular to first standard lead. So therefore, the angle alpha will be plus 90. If you'll get maximal but negative deepest deflection in AVR and 0 deflection in third standard lead, like this, it means
Sorry.
that, yes, any questions? It means that, yes, Jabal, or who that?
Yeah. Can you also repeat this AVR?
In AVR, if you get deepest negative deflection in AVR, largest of all and negative, and 0 deflection equiphasic in third standard lead, third is perpendicular to AVR, Here it is. There's a straight edge. And it means that activation is going away from the positive portion of the AVR. It's coincided to its negative part. Negative part goes by the angle of plus 30 degrees, and it's perpendicular to third. Therefore, the angle alpha will be plus 30 degrees. In manual assessment, typically, if you just use the gauge, you'll measure the amplitude. And well, comparing amplitudes, you need to find out highest or maybe, well, deepest complex that will represent the scheme, well, shown here. Well, trying to find out where will be the highest positive or where will be the deepest negative complex. That will mean that coincide inside that is opposite to the lead of the axis of that lead is the vector of the heart. If you'll get equiphasic pattern like this or like that, it means that this lead, the lead of this axis, is perpendicular to the mean vector of the heart. So there is a, well, straight angle between axis of this lead and patient's mean vector. How it will look like practically? First, you may use the rule of quadrants. Again, well, to find out where to look for, again, we need to remember our classes in secondary school for geometrics. Well, y, x lines, and in our case, instead of y line, there will be, let's erase that, and this, that will be the first standard lead and AVF. Just again, same as your classes in geometrics. And if you'll get positive deflection in both first and AVF, but positive will go down, it means that your patient's angle alpha is in between 0 and 90 degrees. If you'll get deflection between, angle alpha between first and negative portion of AVF. So the domination deflection in the first standard lead will be positive, in AVF negative. It means that angle alpha is between 0 and minus 90 degrees. If there'll be negative in first and positive in AVF, that will give us angle alpha 90 to 180, and both negative. Means that your patient is having angle alpha between 180 and 270. Says yes, if I'm correct. Degrees.
Professor, I have a question.
Yes.
Why is it negative when it's going up and then to the left? Yeah, to the left. Why is it negative? I thought it's like it has to be when it's going up, it's positive, and when it's going to the left, it's negative. You understand what I
Well,
mean?
what is going to the up and down? So he is at the positive electrode of AVF. If activation will go, well, in that direction, in that case, in the AVF, you'll get positive deflection, or more or less, well, closer. If it will go, well, to that direction, that will have positive in first standard lead. So you're talking well about, well, deflection up and then down, about what? About deflection at the ECG or the 6-axis system here? Samaya?
Yes, I'm talking about I think I didn't understand what you said, like with this alpha is from 0 to 90 and then from 0 to minus 90 degrees. I didn't understand this whole thing, I think.
Well, okay. Let's discuss it maybe once again. So, point is that if you have positive deflection, dominating positive deflection in, let's see, AVF. So complex like this: small negative, high positive, and small negative. It means that activation is going well in that direction, in its highest positive. It gives highest positive projection to the axis of the AVF. Here is the positive side of AVF. At the same time, well, this activation that goes vertically down will be projected to the perpendicular axis, and it will result in equiphasic curve with equal amplitudes of positive and negative waves that will result in zero total deflection. So therefore, we'll get maximal positive in AVF and zero projection in first. In that case, we can presume that our vector coincides to AVF. If, for instance, we'll get high positive deflection, it will be highest, but it will be quite similar in AVF and same will be in, for instance, second standard lead. It means that projection is positive, quite high. Here it is in AVF in second standard lead. And vector is going in between those leads. That's why we have same amplitude of projection to one and to another axis. Okay, so it's just like geometrics. That the only difference is that instead of two axes, we have additional four. Same plane, same planimetrics, some certain direction of the vector. We need to project it to axis of the leads, and that's how we can explain what will be shown in the ECG. For instance, if we'll get highest positive in second standard lead is the highest of all. It's higher than in first. It's higher than in AVF. It means that the vector is coinciding, as is shown here by the blue vector, to the axis of the second standard lead, and being in the same direction as the axis of the second standard lead, it is perpendicular to the AVL, because AVL axis is perpendicular to second lead, and therefore the total projection, taking into account negative and positive phases, will be zero in that case. So highest projection in one axis and lowest projection, zero projection in another axis. That will be the basic rule of how we can find out the location of the mean vector. Well, what about the rest? Can you follow me up to now, or it's also not clear? Again, so let's make it simple. And again, we need to start with the first and AVF. So first is horizontal, AVF is vertical. We have positive projections in AVF and in first. So it means that our vector is here. Our projections are positive to first and to AVF. Therefore, vector should be located somewhere in between. It may be plus 30, maybe plus 60, maybe 90, maybe 0, but it's somewhere in between. Then tallest R wave, or you may call it the highest positive QRS net area, highest positive deflection, is in second standard lead. Highest of all, it's maximal of all other projections. Again, Same process projected on different leads. Highest projection is in second. It means that the axis is closest to the axis of this lead, perpendicular to AVL, because it's equiphasic in AVL. That's why it coincides to plus 60 angle, and it's perpendicular to minus 30 angle, like this. Left axis deviation, again, starting from the most rough and then the simple things. First positive, here it is. AVF is negative. Here is the positive for the first and negative for the AVR section. It's upper left quadrant. Where inside that quadrant? We have deepest or tallest S wave in third standard lead. Here it is. And therefore, it means that axis is going along the third standard lead. But because it's a negative deflection, it means that it's located away from the active electrode in opposite direction, in the direction where there is angle minus 60 degrees. Second point, the lead third standard is perpendicular to AVR. So there is a straight edge between the third standard lead and AVR. Let's pay attention to what's happening in AVR. We have almost equiphasic, but well, to my point, the negative deflection is somewhat deeper, somewhat larger than positive deflection here. And therefore, it means that it's not quite exactly minus 60. Please pay attention to the scheme here. What's shown is that the mean vector of the heart is not exactly coinciding to the axis of the second standard lead. It just slightly under that. That's because we have domination of the negative. So projection of the mean vector of the heart is not strictly perpendicular to the AVR axis. It's more on the negative side than on the positive. That's why it's not exactly minus 60. It's slightly under. Another example. What do we have for first in AVF? We have negative in first. We have positive in AVF. And therefore, it's negative first, positive AVF. We have this quadrant first. Second, tallest R wave is in third standard lead. Therefore, it should be somewhere close to the axis, the positive part of the third standard lead, somewhere close to this lead. Another point is, again, it may be close to AVF, but it's high in third, so definitely it's closest to third than to AVF. If it'll be in between, there should be equal positive deflections in third and in AVF. It's high in the third, that's why it closes to third lead, not to AVF. Lead AVR is perpendicular to third standard lead. We have close to zero, but quite definite negative deflection. It means that it's not exactly perpendicular to AVR. It's not exactly 120. It's again somewhere under, somewhere closer to AVF, but not in between. If it would be in between, if it will be the angle 100 or 05, in that case, your patient will have equal, same complexes in AVF in third. They are not. Domination is that of third standard lead. And therefore, the angle alpha that's shown here, it's not 105, that would be in the case of equality of AVF to third. It's more than the middle, but under the 120. That's why it's written that it's 110. Superior right deflection. What do we have? Almost zero in the first, just slight diminution of negative deflection, slight negative part. In AVF, again, negative, but it's quite obvious, quite significant. So therefore, we're talking about this quadrant, but almost zero deflection in first standard lead means that the axis is perpendicular to first and is coinciding to the negative part of the AVF. It's not exactly zero. Termination is a slight part of negative in the first standard lead. That's why we have not minus 90, but minus 10. It's somewhat counterclockwise. That is the visual approach. Maybe I think the most simple approach for assessment for the estimation of the axis of the heart. You just will look at the heart of the patient, the set of 6 complexes, find out where will be the maximal deflection, where will be the deflection closest to zero, and by that you may say what will be the basic deflection. If you get two similar negative deflections, means that the vector is going somewhere in between. The classification is that normal axis should be within minus 30 to 90. That is called normal. It may be, well, there may be some subdivisions, like plus 60 to 90 will be called vertical, 0 to minus 30 will be called horizontal, but they're all normal. Right axis 90 to 180, 180 to minus 90 or 2060 right extreme, and that will be the left axis, minus 30 to minus 90. Good. And now we need to very briefly discuss the features of the hypertrophies of ventricles and atria. For the atria activated mostly in the direction of the positive electrode of second standard lead, from the sinus node, down to the AV node. That is the direction of the cardiac apex. That is the direction to the fifth interspace by the midclavicular line. Therefore, you'll should get positive and the tallest positive P in second standard lead. It should be also positive in AVF, in third, in first standard lead, but it should be highest in second standard lead. And being highest, it should be less than 3 millimeters in second standard lead, and should be within 0.11, less than 0.12 seconds. That is normal intensity of activation represented by amplitude, and normal duration of activation represented by width. Then another extremely useful lead will be first chest lead. It's located almost in between right atrium that hosts sinus node and left atrium. Sinus node will activate left atrium in direction towards V1. Left atrium will be activated away from V1. And therefore, in healthy patient with normal heart, you'll get first positive phase represented by right atrium. It should be larger, both in amplitude and width. And second, negative deflection, smaller again in amplitude and width, caused by left atrial activation. What will happen in the case of atrial hypertrophies? Very, very roughly and maybe in primitive way, let's discuss what will happen to P wave in the case of hypertrophies. Let's start with left atrial hypertrophy. There will be some kind of extra tissue in left atrium, that is away from the normal cardiac pacemaker, the origin of activation of the left, sorry, of the atria, it's in the right. And therefore, it should pass longer way, and it will take longer time to encircle the whole atrial activation. Even if myocardium, the hypertrophied myocardium will be absolutely normal, it will take longer time, but typically it will be abnormal. And therefore, in the case of left atrial hypertrophy, you'll get elongation, widening of the P wave. It will be more than 0.12 seconds, or at least equal to that. First chest lead. In the first chest lead, there will be enhancement of the component that will be produced by the direction of activation away from the lead located at the right border of the sternum. And there will be deepening and widening of the second phase. Second phase will become, again, deeper and wider than the first positive. It may be done, it may be assessed in a relative way, or it may be assessed well, in absolute numbers. It will be, well, if you multiply depth to width, it will be more, equal or more than 0.4 millimeters per second. Then, what will happen if there will be hypertrophy around sinus node, around the origin of activation, extra tissue? While activation will be conducted through a normal left atrium, that time will be enough for activation of extramyocardium around sinus node. In that case, no extra time will be needed. During the normal time, there will be activation of the extra amount of cardiomyocytes, and that will be enough for activation that will be, in that case, more intensive. So current and electrical driving force will be higher. The P wave height will be more or equal to 3 millimeters. And there will be extension of the first positive phase of P wave. It will become taller and wider. It will get to the time when there will be normal activation of the left atrium away from the electrode over the first chest lead, and the negative phase will turn into some kind of defect of the downslope. That will be, well, the only thing left of the negative phase. It will be, well, some kind of the curvature, the negative dome of the downslope of the P wave due to activation of the left atrium. That will be called P mitrale, caused by activation, hypertrophy of left atrium. That will be the P pulmonale. And once again, the same, in the next slides, that is a normal P wave, normal height, normal width, normal shape in the first chest lead. That is the P mitrale, that is wider, and with second top, that the M-shaped P wave or notched P wave in second standard lead, and in first chest lead, there will be enlargement of the second negative component. Right atrial enlargement, the enlargement of the atrium just around the sinus node may result in tall P wave, but of normal duration, and of disappearing of the negative phase of the P wave. That's how ECG in right atrial enlargement may look like. The tall P wave, here it is, attack of bronchial asthma, become taller in comparison to previous state of the patient. And now we need to say a couple of words about ventricular hypertrophies. That is the normal shape of ventricular complex in chest leads. Right chest leads, V1, V2, by the edges of the sternum, while left way laterally from the apex, V5, V6. In right chest leads, there should be a small R wave determined by the activation of septum from left ventricle to the right. Small positive deflection here, small negative deflection in left chest leads. And then there will be almost synchronous activation of right and left ventricles. Left is very potent. So basic direction of deflection will be from right to left. So that vector will be almost hidden. And therefore, in right chest leads, you'll get negative deflection. In left chest leads, positive. That is a normal ventricles. What will happen if left ventricle will become even larger? Well, the normal situation will be just more enhanced. There will be deepening of S wave in right chest leads, and there will be more tau R wave in left chest leads. That may be done very easily, may be assessed very easily by calculation of the amplitude of the R wave. In left chest leads will be taller than 27 millimeters, or it will be more recommended to use the sum of R in left chest leads and S in left chest leads. It will be more than 35 millimeters. What will happen if your patient will have hypertrophy of right ventricle? Well, some kind of equalization. There will be increase in the amplitude of R wave in right chest leads, for instance, in the first chest lead, and RS pattern with equal R and S in left chest leads, like this. Well, if you wish, our time is over, but if you wish, may spend maybe 5 minutes while discussing some samples of the ECG. Do you wish to?
Yes, it's okay.
Good. Okay. So then just will samples of the ECGs from textbooks or from my archive. Just look at that. That is AVF with equiphasic complex. Q is almost same as double R waves here. It means that the axis of patient's heart is perpendicular to AVF. That is AVF. It's vertical. And since it's perpendicular, it should go either in positive direction of the first standard lead, or should go away from the active electrode, the first chest lead. So we need to pay attention to first chest lead, what's happening here. In this case, you have tall, and by the way, it's tallest of all, positive deflection. It means that mean vector of the heart is going in this direction towards positive electrode of first standard lead, and therefore angle alpha is about 0. Then, again, I think it's more convenient to start with equiphasic complex, and I think that equiphasic in this case in first chest lead, same amplitude of R and S waves. And it means that, again, let's draw at least first and AVF. It is perpendicular to first. It should either go, well, down to the positive part of AVF, or go in opposite to the negative part of AVF. It's either plus or minus 90 degrees. So we need to pay attention to AVF, and what you have is a tall positive deflection. And therefore, my conclusion is plus 90 degrees. It's going towards positive electrode of AVF. Then again, equiphasic, quite close to equiphasic in second standard lead. What is second standard lead? Again, AVF. First standard, that is second standard lead by the angle of 60 degrees. Perpendicular to that is AVL. AVL. So here is angle minus 30. So if we presume that axis of the heart is perpendicular to second standard lead, it should be either coincided to the positive part of AVL or go in opposite direction. So in AVL, it should be either tallest positive or deepest negative. It's positive. And in that case, I would say that the angle alpha should be close to minus 30. Its horizontal axis still it may be normal, but close to deflection deviation to the left. Again, here, equiphasic is in AVL, vertical horizontal line, that is the AVL, and perpendicular to AVL is second plus 60. Let's look at the second. We have tallest positive. Therefore, a vector is coinciding to the positive part. So the conclusion is plus 60. Well. I don't see any domination here. What should I do? What should I think about? Well, it seems that we have domination of positive in first, and quite similar to that is AVL. That is positive, yes, and this is positive. I think that it's close to equiphasic, but with domination of positive, 0. And I think that this is quite close to equiphasic, but with domination of negative, 0. Let's try to understand what actually is happening in the patient's heart. We have domination of positive in first standard lead. And as I told you, in AVL, it's also positive. AVL is passing like that. They are neighboring leads. And therefore, our vector should go in between AVL and first positive. So if my presumption is right, it should be somewhere close to minus 15, in between 0 and minus 30. What about second and AVF? Second is perpendicular to AVL. AVF is perpendicular to first standard. So therefore, my presumption is right. And we have a vector that is going in between AVL and first standard lead. It's about minus 13 degrees, 15 degrees, sorry. Good. Here, what do we have is very close to equiphasic, smallest in third. Let's pay attention to AVR. It's quite deep and negative. So it should be minus 30 degrees, coinciding to the positive part of AVR and being perpendicular to third standard lead. In this case, in AVR is equiphasic. Therefore, what's interesting is what's happening in third, and it's deep negative. So AVR is going like that. AVR, that is third standard lead. In third standard lead, it's negative. Therefore, it's going like this. The angle is minus 60. Left axis deviation, like that. I think it's quite simple. So the only thing is that you need to understand that we have same single process. We have one certain event that was recorded by the 6 leads in the same moment of time. 6 different cameras that are recording same event happening in patient's heart. And of those set of 6 leads, you need just to find out what will be the closest to the 0, what will be the deepest of all. Again, deepest or tallest will be pay attention to the summation of positive and negative. So we need to subtract negative from positives to find out what will be the net QRS area. This is important, not only the tallest, for instance, as in that case. In first standard lead, R is quite tall, but we need to subtract negative S. Good. So I think it's not quite complicated. Finding out where will be the equiphasic complex, where will be the tallest complex, will help you to understand to which axis the angle alpha, the vector of the heart will coincide, to which it will be perpendicular. Second rule that you may apply in this case is the rule of quadrants. Again, if you wish, you may remember your classes in geometrics, remembering that you have two axes, almost well, same as geometrics, x and y, first in AVF, and just y-axis will be located directed down. And pay attention, we have positive in first, but we have in AVF negative, and therefore it should be, in that case, in this quadrant. Then look precisely inside what's happening to negative part of third or positive part of AVL, like this. Okay, I hope we have some more time to discuss if something was unclear. Again, we have another class will be on Saturday. So if something was not clear, please prepare your questions, and before, well, next class devoted to arrhythmias, we can discuss all your questions that will may appear during or after today's class. So for now, once again, please don't forget first to use the link at the web page. Actually, I'm tempted not to post any links at the Google Class anymore, because we are forced to do everything only through the web page of the university. I may post a link to the web page, but please use web page of the university. Please, well, website and web page of our department. Second, don't forget to follow the link to the Google Class. Once again, I may post it if you wish to. Do you need that or not? Or everybody already mark the attendance in the Google Forms? No need, I hope.
We need it, Professor.
Need it? So then I'll just will copy it once again, and here you'll get it in the chart. Here it is. Well,
Professor?
sorry, just a moment. Yes, listen to you.
I wanted to ask you, did you record this lesson?
Yes, it should be recorded. I hope it's okay, and it will be posted, well, as usual, in the Google Class. Again, I'll copy the link to the web page, but you may download it from both Google Class or from a web page website of the university. I record all my classes.
But where can I find these classes? Because I just found on the website of our university one video of these lessons, but the others I didn't find. Just one.
Let me see right now. I'll try to enter the web page of university right now. Unfortunately, that will be definitely by the teacher's login. Just a moment. Well, just a second.
Yes.
Yes, I'm hearing you, but I wish to share my screen. Yes, but I just need to find out where is. Can you see my web page of university? So I'm trying to find out my department that is propedeutics of internal diseases, EKM, University of the Clinical Medicine. Here it is. Internal disease propedeutics in Russian пропедевтика внутренних болезней, EKM. Here it is. Then it's Russian called материалы для самостоятельной работы. Here it is. The third link from the bottom. Then объявление is announcements, the news. Here they are. And here you may get all announcements, for instance, seminar, basics of the ECG, that is a link to today's seminar. previous links, for instance, class in auscultation of the heart, April 8th. Again, that is the link to the Zoom conference, like this. And then talking about recordings of the classes themselves, typically I post them in the Zoom. So, for instance, cardiology, auscultation of the heart, class in the Zoom, and that should be the link to the recording, like this. That is the video of the class devoted to the auscultation of the heart. This is the link, and in some time it will be, well, I hope, loaded anyway. You may see it. Okay. Anyhow, if it's not convenient, I'll just post my my videos at the Google Class. If it's not convenient to download from web page, we download from my Google Class. I just attach them to the task in the Google Class, for instance. That is the news line in the Google Class. Tasks, cardiology, and for instance, that's for the sound. That is the video. Can you see my screen or not? I think not. Let me switch to another program and I show to you all them. Okay, again, another link to Google Class. That is the video for auscultation of the heart. So we will download it from the Google Class if website or the institute is inconvenient. Like this. So after the class, I attach to the my slides that I posted here. Good. Okay. Any other questions? Good. If there are no more questions, then that's all for today. Thank you for your attention, for attending the class. It was nice seeing you. Well, at least most of you, because still, well, some of you are so shy that are hiding from me or maybe from your teachers. The topic for the next class will be the arrhythmias. We'll talk about extrasystoles. We'll talk about atrial fibrillation, ventricular fibrillation, and we'll talk about blocks. So if there are any questions, you may prepare them or text me in the chat now, or we'll prepare your questions for the next class. We'll discuss them on Saturday. For now, that's all. Goodbye. Well, thank you all.
Goodbye.
Thank you
Bye.
too.
Thank you.
Goodbye.
Thank you, sir.
Goodbye. Goodbye.